Oh, hello, everybody. My name is Dimitris Kantas. I'm affiliated with the Mayo Clinic in Rochester. Um, I'm also chair of the International Assembly of AASM. Um, um, I'm also secretary of the ERS Assembly 401. Finally, I'm board certified in sleep medicine for European Sleep Research Society, and I'm also a member of the sleep and ICU group of the same organization. Thank you all for joining us for the education webinar hosted by the American Academy of Sleep Medicine in the International Assembly of the American Academy of Sleep Medicine and the European Sleep Research Society. Dr. Lee is my co-chair.
Hi everyone, I'm Pelin Lee from National Taiwan University Hospital. I'm AASM International Assembly co-chair and ESRS member. We are thrilled to feature a presentation on narcolepsy from Dr. Miglis from US and Professor Dr. Giuseppe Plazzi from Italy. Today's webinar is a great example to show the collaboration and sharing of resources from two sleep societies.
The ASM International Assembly brings together vibrant and passionate sleep doctors like you all and allied health professionals from across the globe. With our sleep ambassadors spanning across Europe, Asia, Africa, Oceania, and Americans, our mission is to provide a platform for sleep medicine professionals to connect, exchange ideas and cultures, and learn from peers worldwide.
Before we introduce the speaker, I would like to remind you that your audio is muted and your video is off. We encourage you to include any question on this topic or the speaker in the Q&A platform. This webinar is being recorded and will be available to ASM and ESRS members.
Allow us to introduce the speakers. We have Dr. Mitchell Miglis. He's clinical associate professor in the departments of neurology, neurological sciences, psychiatry, and behavioral sciences. He is director of the Stanford Multiple System Atrophy Center of Excellence and the Stanford Parainsomnia Sleep Disorders Clinic. And he is extensively involved in the multidisciplinary Stanford Post-Acute COVID Syndrome Clinic. Dr. Miglis will share valuable insights into how narcolepsy affects the autonomic nervous system.
Professor Dr. Giuseppe Plazzi, MD, PhD, is a neurologist and a professor of childhood neuropsychiatry at the University of Modena and Reggio Emilia, head of the Narcolepsy and Hypersomnia Center at the IRCCS of the Neurological Service of Bologna, past president of the Italian Sleep Society, past president of the EU Narcolepsy Network. Dr. Plazzi will discuss the clinical features of narcolepsy across different age groups, providing a comprehensive understanding of the disorder's presentation. Thank you for joining us, Dr. Plazzi.
Good morning, everybody, or good afternoon. And so I will share the screen. Those are my conflict of interest. And I will try to show you in these next 20 minutes the clinical feature of narcolepsy of different age. This is one of the most important challenge, in my view, to recognize narcolepsy. Narcolepsy is well-known as a name, disease, and this is a classification of the central disorder. And the clinical feature of narcolepsy at the different age are one of the most challenge for the diagnostic path of this rare disease. And narcolepsy is classified in two forms, as we know. Narcolepsy type 1 with a loss or reduction of orexin in CSF, and narcolepsy type 2. And this is the new classification according to our manual of the International Classification of Sleep Disorder, in which the most important difference is the reduction or loss of orexin 1 in the CSF. And according to this very old definition of narcolepsy, but I think well depict this disease, is characterized narcolepsy by the loss of clear boundaries between sleep and wake during the daytime and during the nighttime, and is also characterized by severe sleepiness with a frequent and unwanted transition into sleep during wakefulness, but also frequent period of awakening during sleep. And patient with narcolepsy, and this is a fingerprint of the neurophysiological study on narcolepsy, is the quick enter into REM sleep. But also REM sleep can appear as a dissociate phenomenon with sleep paralysis, cataplexy, and hallucinations. According to this diagram, narcolepsy is a childhood, a pediatric disease in most of the cases, but unfortunately, in Europe as well as in US, the diagnosis come after years, after more than 1 decade from the onset of the disease. The reason of which unfortunately point is unknown, but one could be also the fact that narcolepsy changed during its disease course, and also the phenotype of narcolepsy depends on the age. And also narcolepsy probably is largely underdiagnosed in all the countries. This is the diagram that shows the increase of cases of diagnosed cases in Bologna in our lab, and you see that after the Italian Patient Association started with awareness campaign, the power of our diagnosis grew up a lot, but also we started to see also these red lines that are the pediatric cases. I will try to define 3 types of phenotypes today. The classical phenotype that I named the Gelino phenotype, the first doctor who described this disease, a childhood phenotype that has been described since the early 19th centuries, and a late onset phenotype that is also very interesting and important to diagnose. Here we see a patient during the MWT, that is one of the tests that are currently used in narcolepsy. And we see that from wakefulness, the transition to REM sleep is very fast, seconds. And then the patient wake up spontaneously here. And also this one is one of the characteristics of narcolepsy, short and refreshing nap, and multiple refreshing nap during the day. The multiple sleep latency test is the neurophysiological diagnostic test, and it disclosed, like in this slide, multiple REM sleep episodes during the day when we ask the patient to lie down and try to sleep. And this validated also for children, but is not validated for very young children. And cataplexy is also the pathognomonic sign. Cataplexy is a sort of paralysis, partial or generalized, that can appear when the patient has an emotion, often a positive emotion, but also sometimes negative emotion. Here we see a complete disappearance of the muscle tone, and the patient fall down slowly, usually. And we can see also that the alpha rhythm of the wake condition is preserved. So the patient fall down into the ground without any loss of consciousness. And sleep paralysis are also very common in patients with narcolepsy. It's not exclusive of narcolepsy, and is a sort of paralysis indeed that appears during falling asleep or at awakening. And like in these videos, the patient tried to shake herself out of this condition. That can be associated with hallucinations from children to adult, and sometimes hallucinations are very disturbing and are not often not spontaneously reported by the patient. And the fifth characteristic is a disrupted nocturnal sleep, as we can see here, with multiple long or short awakening during the night sleep. In children, the situation is different often. The symptoms appear abruptly. Now we can do the diagnosis according to the new classification immediately when we have cataplexy, when we have a reduced orexin in the CSF. So we have not to wait months of observation. Indeed, because narcolepsy is very often an acute onset, and the most characteristic signs are sleepiness and cataplexy. And cataplexy affect children mostly in the face, but also can display, as we will see, different phenotype, and also children, as soon the disease start to display an increase of weight and acceleration of puberty. And some children, prepubertal children, can display a precocious puberty. So this is a typical phase of children with narcolepsy at disease onset, with the hypotonic phases, with the tendency to protrude the tongue, opening the mouth, a bilateral ptosis, and sometimes some facial grimacing, like these children here. But also the neurological examination in these children is typically abnormal, so patient can display an ataxic gait, and a remarkable hypotonia, and cataplexy can be also spontaneous, but is often elicited or increased by emotional situation. We can see here the difference between a girl, normal girl, and the hypotonic features of a child with cataplexy who try to smile looking this funny video. So it's very easy to observe, to record cataplexy in these children. But cataplexy can be also generalized, like in this case, or in this case. The face, you can see, of the children are very similar, but this boy tried to fight against this hypotonia. And also another interesting finding in the children is that falls are very, very brief. And also very young kids like this one, we had all the permission to show you all the videos, was admitted to the IR pediatric unit because of falls and ataxic gait. But also he displayed cataplexy when he eat, like in this case, sweet eating usually. And you have seen that he is hypotonic. He has a white base gait, and he goes on the couch, to try to finish his cookie. What happens to a child with narcolepsy? Well, since the beginning, we see during the day with this actigraphic recording that is very informative in this disease, some episode of sleep during the day, some episode of inactivity during the day, but also a dramatic increase of muscle movement activity during the nighttime. So a dramatic sleepiness, decrease of activity during the day, and a dramatic increase of activity during the night. But what happens to this child, for example, after 10 months? No, after 10 months from the disease onset, he also start to have speech problem, behavioral problem, and also increase of weight, 10 kilos. As you can see, he developed this binge eating disorder, continuous eating, when to be active probably. And cataplexy can be also different from child to child. In this case, we see some different behavior. This is a very floppy boy, and in this case, cataplexy is elicited by the father is asking this boy to do a coffee, and make a coffee for him, for the father. In this case, we see you see only very short, brief break of the smile, and in this case can be not perceived by the patient like a problem, or in this case is very dramatic with the hypotonia. Is this case mimic a muscular problem, a muscular disease. Can be mimic and can be misdiagnosed as a muscular disease. So we have in these boys close to the disease onset negative phenomenon, cataplexy phenomenon, but also a lot of positive phenomenon, like grimacing, stereotypies, or dystonic, dyskinetic phenomenon. What happened to this picture? Well, there is a spontaneous amelioration of all the phenomenon, from sleepiness to cataplexy phenomenon. And you see here, there is a reduction of sleep in the 24-hour. There is a reduction of negative phenomenon, and there is a reduction of negative phenomenon under trigger. And the child often turn from this weakness, dramatic, hypotonic condition to the typical narcolepsy, cataplexy, sorry, that we saw at the beginning in the man suffering from cataplexy triggered by emotion. So we can conclude this first part saying that when narcolepsy arises in children, it's the phenotype is different from what we see in adult. But also in adult, at the beginning, cataplexy can be challenging, recognize cataplexy, because like in this case, and it's not rare, we can see an important activation of movements. So the patient can be a dystonic, dyskinetic aspect, then can also lead to wrong diagnosis. But the most interesting features when we see adults with narcolepsy is again to recognize narcolepsy as a phenomenon, cataplexy as a phenomenon, but also to do not under-evaluate this finding, because patient can have, like in this case, sorry, there is the audio very high, but we see that the patient does not fall to the ground, but is hypotonic. The patient can have wrong diagnosis, for example, for cerebral vascular disorders. So the person, the man, is unable to speak, and you see the disappearance of the anchor reflex. That is also an important sign in the differential diagnosis. But also, when cataplexy arises in elderly patients, can display very long episode of cataplexy, and also, like we see in this video, REM behavior disorder is very, very common in these patients. We can see here the patient is in REM sleep, and it starts with a very long RBD, REM behavior disorder episode. But when the patient is old, also cataplexy can start, and sleepiness also. But we have to pay very much attention, because the patient can have autoimmune disorder, for example, like in this case, the patient has anti-HU antibodies and has a lung cancer. But the interesting thing is that the patient during the night, he has this atypical, very strange movement disorder that is not RBD. And this is a clue for a autoimmune disorder, as we know. What we try to do in Italy with a multi-center effort is to define the different characteristics of patients at different age, and we see that we have an increase of sleepiness, subjective and objective sleepiness during the day, but there is also a decrease of sleep during the day. So the amount of sleep decrease with the age, but since the subjective report of sleepiness increase. And also cataplexy, the triggers for cataplexy can be different, and also anger, negative trigger can appear as the patient become older. And also there is an increase of hallucination, as we can see here, but the motor active phenomena tend to decrease when the patient grow out with the age, but tend to increase again in the elderly patients. And also the episode of cataplexy become longer when the patient become older. And this is also an important information for the clinician for the diagnosis. So in conclusion, I think that the unusual clinical presentation in patients with, for example, the HLA DQB10602 negativity, or normal orexin or low orexin level, are clear-cut clues to suspect other complex condition. And also the peculiar clinical phenotype with higher suggested sleepiness, cataplexy with prolonged attack, frequent sleep hallucination, and RBD are typical in all the patients. But the diagnosis, again, relies on the objective tool that we can use for children as well as for adult and elderly patients. The neurophysiological tools, including the MSLT, including with the MSLT as a gold standard, and also the lumbar puncture that in Europe is very commonly done in the neurological setting. But the last few slides are to emphasize that cataplexy can also be accompanied by functional phenomenon like pseudocataplexy. And again, the neurophysiological instrument that we have can help us to understand if the patient has also, beside true narcolepsy, pseudocataplexy. This is important, for example, in the follow-up, we want to judge the effect response to the drug that we have, and also pseudocataplexy can appear in older people like this one. And in Italy, again, sorry if I mention Italy, but I am Italian, we try to design red flags to facilitate the early referral of people with symptoms of narcolepsy. And we distinguish red flags for pediatric patients that are not only complaining of sleepiness, cataplexy, and hallucination, other sleep-related phenomenon, but also the signs of precocious puberty and the increase of weight until the development of obesity. And this case is very recommended that the presence of excessive daytime sleepiness and cataplexy has to be investigated. And again, patient with daytime sleepiness, adult patient with daytime sleepiness and cataplexy can be sent directly to the sleep center of reference of the region, but also we have to investigate the presence of excessive daytime sleepiness and cataplexy in patients presenting with peculiar sleep-related disorder and also associated with impaired nocturnal sleep. So thank you very much, and thank you to the Italian Patient Association that gave us support in every step of our research.
Thank you for
Yes,
your
thank you for the wonderful
interesting
talk. And now join us, Dr. Miglis.
Thank you, Dimitrios, and it's a pleasure to be here this afternoon, presenting with Professor Plazzi. I was just in Bologna visiting his group 2 years ago, and it's a beautiful place. I look forward to going back. So happy to be here virtually. So we're going to switch gears now. I'm going to be speaking for the next 15-20 minutes on autonomic dysfunction in narcolepsy, a probably more recently researched component of narcolepsy and in sleep in general. So I always like to give this introduction. Why are we even talking about the autonomic system? Well, I think we're realizing with a lot of disorders, including sleep disorders, that most all of the sleep disorders that we see can cause autonomic imbalance or autonomic disease. Sleep apnea is a great example, but there's a lot of evidence in the CNS hypersomnias, including narcolepsy, that we'll talk about. And in the autonomic clinic, in the neurology clinic, we see most all the autonomic disorders have sleep disruption as a component of them. So it's really a bidirectional relationship. And if we think about it, sleep is in essence an autonomic function because we're doing all of these things automatically, unconsciously, right? So as an intro to autonomic dysfunction in narcolepsy, it's important to just understand that there are several areas in the central nervous system that control autonomic outflow or integration, and we call this the central autonomic network. And there are many neurons in the hypothalamus or autonomic centers in the hypothalamus that are important for autonomic control, including vascular regulation and temperature regulation. Of course, we're talking about the hypothalamus. We also think about feeding and alertness with hypocretin orexin. A lot of these nuclei are also further down in the brainstem, in the pons, and a very important center is in the lateral medulla. And this is very important for the baroreflex, which is involved in sleep and often gets disrupted with some of these disorders. So the clinical evidence for autonomic imbalance or disease in narcolepsy, the studies are fairly recent. I'm going to just introduce two sort of epidemiological studies. A caveat is both of these were sponsored by a pharmaceutical company, but I think they illustrate some important data. The first was a retrospective claims analysis called the BOND study that evaluated incident rates of cardiovascular or cardiometabolic comorbidities in a very large group of U.S. patients with narcolepsy. This included type 1 and type 2, and compared them to a very large group of controls on a 5-to-1 basis. These cardiovascular events were recorded at any point in the patient's medical history, so it wasn't necessarily development of cardiovascular comorbidities after diagnosis of narcolepsy. It was any point within the patient's lifespan. Nonetheless, the odds ratio of several cardiovascular events were higher in patients with narcolepsy. I'll show you that slide next. I think a slightly better study was a follow-up one that was done by the same company that also did a claims analysis of 54 million U.S. adults. And they found that patients with narcolepsy had higher incidence rates of new onset cardiovascular comorbidities. So these were new diagnoses after the diagnosis of narcolepsy. And we can see the adjusted hazard ratios here at the top. Several cardiovascular diagnoses of interest and cerebrovascular, myocardial infarction, ischemic stroke, major cardiac events were all higher, significantly higher in narcolepsy patients compared to controls. And this is from the first of those two studies, the BOND study, showing that, for instance, a 2.5 increased risk of stroke. We included also myocardial infarction, cardiac arrest, and heart failure. So raising a slightly concerning safety signal regarding cardiovascular, cerebrovascular comorbidities and narcolepsy. Not all of these might be influenced by the autonomic system per se. We also know that the diagnosis of narcolepsy imparts also a greater risk of other cardiovascular comorbidities, including obesity, hypertension, diabetes, and dyslipidemia. So some of these effects might be due to the other comorbidities that develop with the diagnosis of narcolepsy. Nonetheless, this has prompted more recently expert panel consensus recommendations that advise all sleep clinicians to consider this risk and to recognize as well that patients with narcolepsy have increased risk of other sleep disorders, including sleep apnea, restless leg syndrome, and PLMD, and those themselves also impart an increased cardiovascular risk. And just to be aware of these comorbidities and to pay special attention to blood pressure, weight, etc., and treat all the comorbid sleep disorders these patients have, and then also to consider their diet and perhaps their salt intake. So getting to autonomic symptoms, not many studies out there, but this was one that looked at drug-free patients. I think this is important because a lot of course, our narcolepsy patients are on stimulant medications, wake-promoting medications. These themselves increase blood pressure, increase heart rate. But in a sample of drug-free patients, high percentages of them reported not only cardiovascular autonomic symptoms, lightheadedness, racing heart, etc., but also a lot of GI discomfort, urinary symptoms, thermoregulatory symptoms, and even sexual dysfunction. But in this study, there was no correlation between the severity of the autonomic symptoms and either the disease duration or orexin hypocretin levels. This cohort did have orexin hypocretin CSF levels measured. This is also an important point that some of these studies that I'll mention did not measure orexin hypocretin. So that might play a role in some of the disparate findings. So I mentioned the central autonomic network. Orexin hypocretin projects to many of the nuclei of this autonomic network. There are sympathetic nuclei that receive projections from the orexin hypocretin system, including paraventricular nucleus, nucleus tractus solitarius, which I mentioned in the medulla, the rostroventral medulla, IML in the spinal cord. And there's also projections to parasympathetic or vagal nuclei, dorsal motor nucleus of the vagus and nucleus ambiguus. And so it's a very complex, neuroanatomical system. Don't ask me specific details on some of this. It's really not known because it is so complex. And I think the point is that because of the complexity, orexin hypocretin might have several different modulating effects. It might not only just say increase sympathetic tone or decrease parasympathetic tone. It might do both in different situations. And some of the animal studies have suggested that. So, for instance, most of these studies are in rat or mouse models. Orexin hypocretin injection into the lateral ventricles and the hypothalamus has shown to increase sympathetic drive, which we think fight or flight, what would that do? Increase blood pressure, increase heart rate, body temperature, etc. And that occurred in a dose-dependent manner. Similarly, injecting orexin hypocretin into the medulla also increased blood pressure and heart rate. However, injecting orexin hypocretin into the nucleus tractus solitarius decreased heart rate, but at higher doses it increased heart rate. So there was a dose-dependent response. And injecting it into the nucleus ambiguus, which is a vagal center, parasympathetic center, decreased heart rate. So there's somewhat conflicting results, but most of the animal models have shown that if we increase orexin hypocretin, it seems to increase sympathetic activation, increase heart rate, increase blood pressure. In human studies, there are a lot of studies looking at heart rate variability. This is often cited in the sleep literature as a surrogate of autonomic balance. It's not a precise measure, but the point I want to make here is that as in the animal models, there are conflicting results. Most of the studies have shown that patients with narcolepsy, most of these studies are in type 1 narcolepsy, that these patients have an increase in the low frequency component of the heart rate variability, which correlates with sympathetic activation. But this may be state dependent. So more of the increases have been found in wake before sleep or lighter stages of sleep. And during sleep itself, those sympathetic imbalances might go down and might decrease. For the sake of time, we'll just skip this. Another very important point to make is that multiple studies have shown that patients with type 1 narcolepsy are non-dippers. And we know that lack of dipping, as we see in OSA, suggests an increase in sympathetic tone, and it imparts a cardiovascular risk in and of itself. So the first study to show this was out of the Bologna group, and they demonstrated that both systolic and diastolic pressure, as well as heart rate, are higher in patients with narcolepsy overnight compared to controls. The absolute difference in, say, systolic pressure was not that much different, however, except in REM sleep. We know that REM sleep is the state where sympathetic activation is at its highest. And in fact, in REM, our sympathetic system can be at a level that's higher than it is when we're awake. So during REM, patients with narcolepsy really had that their dipping was much more pronounced. Their blood pressure was much higher than controls. Another study showed the same thing, specifically with diastolic pressure, that there was lack of dipping. And this also was correlated with sleep fragmentation. So another, potential explanation for, perhaps why narcoleptics have increased cardiovascular risk, or they might have increased blood pressure or lack of dipping, is the very fragmented nature of the sleep. And we know that sleep fragmentation with all the microarousals also increases sympathetic tone, and lack of sleep consolidation will increase sympathetic tone. And that's what this particular study demonstrated, that the longer the wake bouts during the night, the longer the amount of time narcoleptics were awake with these arousals, that actually correlated with the hypocretin level. So the lower the hypocretin level, the longer the duration of wake bouts that they had throughout the night. And one could hypothesize that perhaps that could increase sympathetic activation and be somewhat responsible for lack of dipping. Interestingly, there's a lot of paradoxes in some of these studies. Some of the studies have shown, somewhat opposite findings. For instance, this was a study that also came out of the Bologna group, in which they directly measured sympathetic activity during wake in a small group of type 1 narcolepsy patients and compared them to controls. So they used a technique called microneurography, where there's a very small sort of EMG needle that is directly inserted into branches of the sympathetic nerves in the leg, and they can directly measure sympathetic burst activity. And what they found was that patients with type 1 narcolepsy had actually decreased sympathetic activation compared to controls during wake. And they also had lower blood pressure during wake. They also correlated the sympathetic burst activity with hypocretin levels and found that there was a direct correlation between the two. So lower sympathetic activation correlated with lower hypocretin levels, and that's also correlated with lower heart rates, suggesting that at least during wakefulness, some patients with type 1 narcolepsy actually have reduced sympathetic activation, at least measured in this fashion. Another study, which Dr. Plazzi was last author, did the same sort of analysis, but during sleep. And they found that patients with type 1 narcolepsy had actually lower sympathetic activity during SOREMs compared to normal sleep. This study may not have as direct a correlation with of the other studies I'm mentioning, but it is interesting in that it sort of demonstrates that the SOREMs of narcolepsy have a different physiological probably origin and a different association with autonomic activation than normal REM sleep. They found that in normal REM sleep, the actual sympathetic activity was fairly normal and actually no different than controls. But in the SOREMs, there was a lower sympathetic activity. So they suggested that that there's limited hypocretin influence on sympathetic activity actually during sleep, and that the SOREMs, represent a sort of dissociated state and not part of the kind of normal sleep physiology and architecture. Very busy slide. This is just to point out that, like, the animal studies and some of the other human studies mentioned, there are somewhat conflicting results when we do sort of the standardized autonomic reflex testing in our autonomic labs. We'll see somewhat disparate findings. A lot of this also comes from the Bologna group, but others have done this. And I think the theme is that generally there is evidence of increased sympathetic activation and decreased parasympathetic activation during these studies. None of the studies have really focused on the diagnosis of comorbid autonomic disorders like postural tachycardia syndrome or syncope, which I think is important for future studies. Most of these studies have just looked at the sort of physiological kind of measures of autonomic cardiovascular control. And again, while there are somewhat disparate findings, general theme was that there is decreased parasympathetic activity and potentially increased sympathetic activity. One study looking at autonomic innervation of the heart showed no abnormalities. So this argues that there's probably not a strong peripheral autonomic dysfunction in narcolepsy, as one would hypothesize that it's probably coming mostly from a central etiology. So I think a lot of this is important to consider as we're moving forward and seeing these trials with orexin agonists, and we're going to see these drugs come to market. In the study published in New England Journal last year, there was a safe, somewhat mild but important safety signal of patients that were treated with this orexin agonist, that it did increase blood pressure and heart rate in a subset of patients. So I think considering cardiovascular risk, we're going to have to pay attention to the cardiovascular effects of orexin agonists, because even though the findings are somewhat differing, the theme is that, at least in a subset of patients, orexin hypocretin does increase blood pressure, increase sympathetic activation. So somewhat different findings. I think this comes down to different methodology in these studies. Hypocretin orexin was not measured in all the patients. And there's a disease heterogeneity here, which I think Dr. Plazzi spoke to. But my final slide is, what is the mechanism here? I mean, there's definitely something there, but what is causing it? Well, I think, even though the anatomy is very complex and we don't fully understand all of it, there definitely is an association between hypocretin orexin pathways and central autonomic network. There might also be an element of immune dysregulation. We know that's the case in type 1 narcolepsy. And there's a potentially higher frequency of comorbid autoimmune conditions in these disorders. And then we have to always remember sleep fragmentation. Anything that fragments sleep increases sympathetic tone. There's also the increased vigilance to fight against sleep in patients with narcolepsy. That in itself might increase sympathetic activity. And these patients, sleep a lot, or they sleep at inopportune times, so they're not really exercising as much as they should, and that itself increases cardiovascular risk. And finally, narcolepsy by itself is an independent risk factor for all the other sleep disorders. We think of that increased sympathetic activity. So I'll stop there and open to questions.
Thank you, Dr. Miglis. Great presentation. Now we have some questions, but time is pushing us. But two questions. Says in type 1 narcolepsy, are orexin 2R agonists believed to be more effective, beneficial than non-orexin drugs in preventing, addressing cardiovascular risk and autonomic systemic issues?
So, sorry, Demetrius, can you read that first part again? Just trying to understand the comparison there.
Okay, in type 1 narcolepsy, are orexin 2R agonists believed to be more effective and beneficial than non-orexin drugs in preventing cardiovascular risk and autonomic dysfunction?
Right. So I think it's unclear. We don't have a lot of data with these drugs yet in type 2 narcolepsy. Those studies are ongoing, but not all companies are focusing on type 2 initially. My opinion is that there's still going to be a safety signal there, even though theoretically there's less hypocretin deficiency in type 2. I mean, there still could be some hypocretin deficiency. But regardless, I think any drug that is stimulating these receptors is going to increase potentially sympathetic activity, blood pressure, and heart rate. So we'll have to wait for more of the data, but I would think there's going to be some similarities there.
Okay, thank you. Some questions from for Dr. Plazzi. It's we have some. I have to pick some. Unfortunately, did all of the children shown in your videos have an MSLT? And do you consider performing a split night study in such children with history of cataplexy? how often do you perform CSF hypocretin and HLA matching? And also another question, I mean, how easy you perform this test in Europe, hypocretin orexin levels?
Well, I start from the last. In our center in Bologna, but was as well as also in other centers in Europe, big reference center like Montpellier, Leiden, we do orexin level to all the patients. And also with patient with not complete REM narcolepsy finding, like idiopathic hypersomnia patients or narcolepsy type 2. So we do, but we do it by research. So it's not paid by nobody, but it's paid by the research, by us.
Okay, and what about HLA matching?
Yeah, we know that 98% of the patient carry the HLA, it could be 10602
okay.
antigen.
And thank you. And what about MSLT? Do you perform MSLT in all your children?
We do MSLT to all the patients. All the patients are investigated for night sleep, MSLT, MRI, because we have to remember that narcolepsy can be a secondary disease, and we do lumbar puncture to everybody.
Okay. Also, do you exclude epilepsy with full head EEG? You know, the 24.
Yes,
probably.
during the monitoring we use a complete EEG monitoring, night and day.
Okay, and another question from you. I'm not sure if you cannot, if you can answer it. It says, did the 2-year-old have Prader-Willi or any identifiable cause of narcolepsy cataplexy, the one that you showed in your presentation?
Well, we have patients with narcolepsy cataplexy and Prader-Willi syndrome. Nevertheless, the 2-year-old boy is a genuine narcolepsy type 1 patient. So we do also genetic, of course, in children, but we do a panel for Prader-Willi and others, but this is not a Prader-Willi. It's a normal narcolepsy patient.
Okay. There is another attendee says that I have been treating idiopathic hypersomnia for several years. I have noticed that many symptoms have gotten worse. Extreme urge to sleep after eating or with intense emotions. Should I be seen by my physician again? Probably it's a patient.
I could just comment on that. I think this talk was focusing on narcolepsy, but I mean, in my experience, the autonomic symptoms are worse in idiopathic hypersomnia than in narcolepsy. I mean, there might be some gender, component to that. I mean, so I think we see more females in IH, and that carries potentially more risk of some of these orthostatic disorders. But we're looking into this. I've seen a very high rates of orthostatic disorders, especially POTS and IH, and we don't see that as much in narcolepsy. So I don't know if that's related to gender or there's other mechanisms there.
Okay, thank you. What about the use of antidepressive treatment, the MSLT results?
Well, the MSLT results are altered by the use of antidepressant. So it's important in this case in patients who do not allow, or the condition is very severe, so we cannot wash out from antidepressant to do the lumbar puncture. Because an MSLT can be negative, can be normal with antidepressant.
Okay. Unfortunately, we have one last question, and it's someone says, how can I diagnose narcoleptics in OSA patients? That's an easy one. Right.
With the lumbar puncture, with the orexin levels. It's the easier way to mismatch.
Okay, since it's time to close this excellent discussion, and we would like to thank our two distinguished speakers, Dr. Plazzi and Dr. Miglis, and also thank you everyone who participated today. We would like also to thank our ambassadors worldwide. They are an important group of people that work with us.
Thank you, everyone. Finally, we invite you to learn more about the AASM and ESRS and become the dual member.
Thank you, everyone, and see you next time, right?
Thank you.
Thank you. Goodbye.
Thank you.
Bye.
Goodbye.